Welcome to our last week, week 8 of Theories of Addictions. This week, I'm going to be covering behavioral, or what we also call process addictions. Up to this point in the course, we've been looking at theories of substance use disorders. Now, in this last week, we're shifting from substance use disorders to behavioral or process disorders. The difference for some people can be a little bit confusing, whereas for substance use disorders, the focus, the addiction is with respect to the substance. There are behaviors associated with a substance use disorder. For example, compulsive drug seeking may be a behavior, but the compulsive drug seeking is not the disorder, is not the addiction. The addiction, the object of the addiction is the drug. Whereas in process disorders, the object is not a drug. The object is a behavior or a process. So don't confuse those. They're determined by the object of the addiction. If the object of the addiction is a substance, it's a substance use disorder, even though there will be behaviors associated with it. If it is a behavioral or process addiction, then the object of the addiction is the behavior. So if you think about that, then you shouldn't get that confused. Compared to substance use disorders, behavioral addictions have only recently gained some attention. And this is reflected in the DSM-5. There is one actual behavioral addiction that is specifically mentioned in the chapter of the DSM-5 that deals with addiction. So it is listed at the end of the substance use addictions, and it is a behavioral addiction, and that is with gambling. Gambling has been studied for years and years, so we do know considerable information about that. So the first behavioral addiction that I want to look at is gambling. Now, one thing to keep in mind as we look at these behavioral addictions, again, also co-process addictions, there are comorbidities. And one of the comorbidities may be a substance use disorder, but we're focusing on the behavioral addiction. Now, I will bring up comorbid substance use disorders at some points in the discussion of the various forms of behavioral addictions. As I said, the gambling is specifically mentioned and covered. The diagnostic features for it are in the DSM-5. And so what I want you to do for this course is go to the DSM-5 and look at the diagnostic criteria for gambling, and then look at the diagnostic criteria for any of these substance use disorders. And you will see overlap in those diagnostic criteria, okay? And as we're looking at other behaviors that are not in the DSM-5 right now and then objects of addiction, then gambling will serve as kind of a prototype there. So the diagnostic criteria for gambling have been kind of used as a model for understanding other behavioral addictions. And we are expecting that some of what we will be covering in today's lectures will be these behavioral addictions. We would expect more and more of them becoming more prominent within the DSM-5. The prevalence of gambling in the United States and the world is extremely difficult to determine. There are some studies that show that at least in the United States, between 1 and 3% of the entire adult population has a gambling problem. And we do know some information about the individuals who tend to kind of gravitate toward gambling addiction. One, males by far outnumber females in terms of having a gambling addiction. We do know that African Americans have a higher incidence than Caucasians when it comes to gambling, and a lot of this will be due to the issues that we covered in the last lecture on cultural issues there, and with minority stress, it predisposes many minorities, not only African Americans, but any of the other minority populations under continued stress, so that gambling would be a bigger issue. Sex addiction, which we will look at today, is, again, that's really hard to get a number there because of the shame surrounding that for many individuals. But the numbers tend to gravitate to between 3 and 6% of the adult US population there. When we're looking at eating disorders, and I will not be covering eating disorders per se, however, with certain of the other behavioral addictions, we do see eating disorders associated with them. And so, for example, anorexia nervosa, which is largely a problem of females, is about 4% of the US population there. Bulimia nervosa, another eating disorder, has an incidence of between 1 to 1.5% of the adult US population. Internet addiction is one that has just really increased in prevalence over the past number of years. And so, for example, if we look at just the university students, we see that internet addiction hovers between 6 and 10% of that population. The behavioral addiction that has the highest incidence of all of the behavioral addictions, some people even question whether it's even a real behavioral addiction, is workaholism. And that is about 31% of individuals self-identify as having a workaholic addiction. It's much more culturally acceptable to confess workaholism than, say, a sex addiction or a gambling addiction. And then the other one that I want to look at today as exercise addiction. I mean, there'll be others that I'll cover, but exercise addiction is, again, between 3 and 5% of the US adult population. However, the group where we see a really prevalent incidence of exercise addiction are the university students, and the estimates are between 22 to 26% of that age group or that population struggle with exercise addiction, and so we'll cover that. So if we look in the United States about the take workaholism kind of out of the picture initially because of the prevalence, but if we kind of normalize those figures, we see the top 5 in terms of incidence, and I'm not rating them in terms of incidence, would be gambling, work, sex, video games, and exercise. The other types are compulsive buying or shopping, and tanning addiction, which has increased. I won't be covering tanning addiction today, but I will look at some compulsive buying and spending addiction, some facts about that. But let's jump into a little bit more about a gambling addiction. Typically, a gambling addiction begins somewhere in the adolescence, and we see in the progression, it seems to be phases in intensification or increasing symptomatology, is that it moves to financial losses, and then after the financial losses, then we see major functional impairment. things going wrong in interpersonal relationships, in the job, financially, loss of money. And so with that, there is guilt and shame. And so we see the result in concealment of the problem there, which just intensifies that problem. Typically, it is young males that we see as having those gambling addictions, and that age group is kind of on the rise. The kinds of gambling that they get involved in are different than the kinds of gambling that we see with older individuals with the gambling addictions. With young men, it tends to be sports betting or cards, baseball cards, those kinds of things, or even horse racing tends to be rather prevalent in that age group. In older individuals with a gambling addiction, we see more games of chance, maybe the slot machines or bingo. And bingo is a kind of big social thing, and many bingo games are held in the public, and some are even attached to churches. Okay, so what we see, though, a difference between the young males and the older individuals with a gambling addiction is a very, very low percent of young men who have a gambling addiction seek help. Older females, especially older females, gambling can be quite problematical. They are going to be more likely to seek help, but even numerically, the percentage of them seeking help hovers right around 10%. So 90% of the older female gambling addicts are not seeking help for that. What's caused the huge rise in this is really the internet. So much gambling is available on the internet. And the online gamblers, if we look at that profile, they tend to be younger, tend to be male, single, they're not married. They're surprisingly, they're full-time, they're employed full-time, and they have an income that's greater than the average American population. So they have a higher income. They often also have a co-occurring substance use disorder. About 13% of these younger male gambling addicts that are online gamblers have a substance use disorder. There are some special populations when we're looking at gambling addiction. A large percent of the individuals have a history of trauma, and about 64% of the individuals with this addiction are trauma survivors. 41% were physically traumatized, and 24% were sexually traumatized. 60% of the female gamblers have had PTSD, either due to physical or sexual trauma. And 16% of the men have a diagnosis of post-traumatic stress disorder, a trauma disorder. Okay? What we see in terms of the difference, the motivating factors, with younger gamblers, it is kind of excitement and taking the risk, etc. In older individuals with gambling problems, most often they gamble to relieve feelings of distress. And when we're talking about those feelings of distress, specifically there are two types, and that is anxiety or depression. So these are emotion driven. And with those dysfunctional emotions, then the way that they self-soothe will be through gambling. Another special population is the forensic population. 40% of those in correctional facilities were engaged in gambling, although the gambling of the forensic population is lower than the percent is lower than the national average, but a good number of those individuals in prison systems, 40% were engaged in gambling. So again, I want you to go to the DSM-5 and look at the diagnostic criteria for the gambling addiction. I'm not going to be covering them now. I'm leaving that up to you to go look at. Now let's shift to what's available for treatment for these individuals. Well, it's very interesting because most of the treatments we've already covered in this course, and one at the top of the list for gambling is the trans-theoretical model. Remember, Prochaska's stages of change model is a trans-theoretical model. And so as you remember with the trans-theoretical model, at each of the level of level of motivation or level of readiness for change, there were specific interventions that were mentioned. And some of those interventions are going to be the same for treating gambling. For example, one recurrent treatment that was seen as helpful and associated with the trans-theoretical model. The trans-theoretical model cuts across all treatments, but one of the really helpful treatments for individuals in that readiness of change, levels of change, was cognitive behavioral. And in fact, that tends to be the treatment of choice. And just go back and review the cognitive behavioral models, and because we discussed that in some detail. Medication has been used, and at the top of the list for the medications were the antidepressants, specifically the SSRIs have been helpful. But not only that, naltrexone, an opioid antagonist, has had some help, and in terms of reducing the craving. So this urging or the craving to go gamble has been alleviated with naltrexone. Self-help groups have arisen around gambling, Gamblers Anonymous. All of those helpful, and we would see that the cognitive behavioral and medication would probably be, the outcomes would be a little bit better than with the self-help groups alone. By the way, many individuals can seek psychotherapy such as cognitive behavioral therapy or be on meds and also participate in a self-help group. It's not like you have to choose one or the other with respect to that. Okay. That's about what I have for gambling. Now I would like to move to another behavioral addiction, and that is sexual addiction. Frankly, there's no agreement on among researchers on whether that is an addiction or not. But there's a growing realization, a growing awareness, and a growing sense that it is indeed an addiction. I do want to separate that and direct you to the DSM-5 to look at a section of the DSM-5 called the Paraphilias. The Paraphilias are abnormal or dysfunctional ways for someone to act out their sexual desire. Paraphilias often are illegal, at least in the United States. Frauderism, getting sexual relief by rubbing up against somebody, voyeurism by watching individuals engage in sex, or exhibitionism by, we used to call them flashers. They will expose themselves, or even things that are highly illegal, such as pedophilia, right? So I would like for you to go to the DSM-5 and look at the diagnostic criteria for each of those paraphilias, because we would put them in as a special class among the sexual addictions, okay? What's the prevalence of sexual addiction? Well, again, no one really knows because of the shame and embarrassment that can surround that, but typically they believe it's somewhere between 3 and 6% of the adult population. It's not in the DSM-5. And one of the things that we look at with sexual addiction is compulsivity to act out sexually. So what, in terms of gender there, males have apparently experienced larger numbers of sexual compulsivity than females. And then there are special populations among the sexual addicts. One are hypersexual men, just a very strong sexual drive that kind of act out, and we see this within the paraphilias. Paraphilias are, numerically, there are more males than females engaging in the paraphilias. However, another population, a subpopulation among the sexual individuals with sexual addiction are women survivors of PTSD or trauma. About 63% of individuals with PTSD, 63% are female who have been physically abused and 51% sexually abused. For males, the numbers are a little bit lower. 25% have been physically abused and 8% sexually abused. And then there's also paraphilia, sex abuse. And again, let me go back to the paraphilias. All of those are problems of sexual desire. The object of their sexual desire is considered to be abnormal. Okay, what do we do in terms of treatment? The treatment is, interesting, and that is that a lot of individuals go to 12-step programs. Carnes and some of those individuals who have done research over years and years, they have been involved in 12-step program and have developed Sex Addicts Anonymous, which is rather prevalent and probably for years was the first line of defense. One very helpful way that it has been looked at is with motivational interviewing, and that makes perfect sense, right? Because the motivational interviewing is a strengths-based, so they're not going to be, and it's very positively oriented and uplifting, so that it's not going to be involved in any shaming or blaming, and so a very good way to entryway for the treatment of individuals with sexual addictions. Medications have been used. For example, a good number of sex addicts have experienced anxiety and mood disorders. And so we would see one of the most common medications given to sex addicts would be the SSRIs, the selective serotonin reuptake inhibitors, which is kind of an antidepressant. Remember, those antidepressants are also given for anxiety disorders because the meds that treat, and the anxiolytics, the meds that treat anxiety, are highly addictive. Group therapy. One of the benefits of group therapy is that by talking about this in group, you're acting against the shame, you're acting against the guilt, and so we see shame lowered in those groups. Psychoeducation is tremendously important. For an individual to know what drives the sexual addiction, particularly if it's based in anxiety or depression or trauma, it really needs to be investigated, explained very well. It's very helpful if psychoeducation, that kind of information, is tied to the 12-step groups that are highly prevalent. A final treatment has been EMDR, eye movement desensitization, is a treatment for PTSD that has high research support. It's an exposure-based treatment, and but there are other evidence-based treatments for PTSD that would be very helpful for those. Trauma therapy for somebody with a sexual addiction, it is imperative that we assess for the presence of trauma in their history. And if trauma has been there, then it is probably a very, very good idea to assess for the need for trauma therapy, especially if they've not had any kind of counseling or therapy for trauma. It is really important when you're looking at trauma treatments that you do use evidence-based treatments. There are some treatments for trauma that are not evidence-based. The ones that are, if you go to the American Psychological Association Division 12 website, it'll list those evidence-based treatments, and it'll tell you the level of research support that backs those treatments. It'll say whether there's strong research support or moderate research support. There's one treatment for PTSD that has modest research support. And then it'll also talk about treatments that have no research support and that are particularly harmful. So it's really important to use an evidence-based treatment for, if available, for the treatment of trauma, and always assess for the presence of trauma when we are looking at sexual addiction. Now, and I want to move to another one that people sometimes just joke about, but it is not a joke. It has really, really serious consequences, and that is workaholism or a work addiction. Again, it's not in the DSM-5, and people disagree with it, but given the consequences, it's really a serious condition. There are certain key features that we see with individuals who are engaging in an addiction to work. And that is they have obsessive work thoughts. Remember, there are obsessions and compulsions. Compulsions are actions, obsessions are thoughts. And so individual with workaholism has thoughts about work just obsessively. They go over and over and over them. There's also compulsive behavior. They work compulsively, they work too much. And so there's not only the thinking, the obsession, but there's the compulsivity in terms of behavior that is seen with workaholism. Often the problem is that they have positive work outcomes, because people who work really, really hard often get a lot of work done and get feedback and praise for the work that they do. So they're inadvertently rewarded for their workaholism. So that's problematic. However, accompanying that, some positive work behavior, and not all of it's going to be positive. As the workaholism progresses, work productivity can actually go down. But associated with workaholism is often poor social outcomes. People have overinvested in work and underinvested in social relationships, or even their own personal growth, entertainment, and recreation, and things like that. Again, there's considerable discussion about whether it's really, really a problem. Again, there's growing awareness that the behavior is problematical, though. So some studies have classified the types of workaholism that we see. One of those would be perfectionist. And perfectionism has its roots in demandingness, that what we do, we have to be perfect at it. And so that irrational demand upon the self about one's productivity and the quality of one's work can be problematical. Now remember, we're not saying that it's not a good idea to do good work. We're not saying that at all. We're talking about why the individual would be focused on doing well. If it comes out of their values, they would like to do that, it's a great idea, etc., that's fantastic. But if an individual believes they absolutely must and they're compulsive about it, that can be problematical over time. The other one, another kind of type is an individual who is a workaholic and they are intolerant of the the perceived incompetence of the people around them. So they're highly judgmental of the behavior, of the performance of those around them. They're demanding about others rather than about the self. And so, but they go, well, then I must do it if they can't do it, and they should be doing it, right? So that demandingness, or even putting others down within their mind, that global negative rating of the other person, is like another type there. A third one is individuals who are just motivated by advancement and power. That's the reasoning behind that. That's the desire there. And others, because they do get feedback, positive feedback at work, and then they've slighted investment in relationships, sometimes they don't get positive feedback at home. So the work environment is more pleasant than the home environment, so they overinvest in the work and become workaholics there. And then there is the others that are a little more, a little healthier about it, is that they realize that there's a problem and they are trying their best to set limits on the amount of work that they're doing. And then finally, for some individuals, it's more situational. They are driven by job security. So for example, during COVID, so many of the jobs went away and people were worried about losing their jobs. So they were really, really sometimes overly investing in the job. Totally understandable. And that situational kind of workaholism can be problematical over time. Even, for example, if the job security increases and the person is really compulsively focusing on the work, even when there's no job insecurity, then the behavior is more problematical. There are numerous negative outcomes of workaholism. Anger is tremendously important, and we know that in the treatment of anger, that usually the cognitive behavioral models are really, really helpful for that. Anxiety, same kinds of treatment that we've already looked at. So anger, anxiety, also just burnout, just burned out due to the stress that they experience by the pressure that they put themselves on. So they can just be physically exhausted and just burned out from the job. Depression can be a major, major problem with workaholism, and those are all emotional issues, but there are also physical issues. There's a greater incidence of heart disease in individuals with workaholism and other associated health problems such as high blood pressure, etc. And which makes many people believe that workaholism is due to stress, and stress over a long period of time contributes to a number of medical conditions, including diabetes, etc. So individuals who are workaholics have a higher incidence of suicides. So that is a public health problem. They have, with anger directed toward other individuals, because anger puts the other person down. They don't necessarily have to say it, but they're thinking that the other person isn't good or worthy or productive or whatever. And then having demandingness around them, that may contribute to conflict with coworkers, and so the work situation can be problematical and increase the stress for the workaholic. And then one personality feature is we see cynicism set in, that and cynicism can mean that there is a distorted meaning attached to work too. So all of these are really, really negative outcomes of workaholism. Well, other thing is that has been studied and found in research is that those individuals who tend to work compulsively for extrinsic reasons, for like power, for money, etc., or they work, or they're compulsively out of fear of punishment, have a higher level of exhaustion. So if the reward is extrinsic rather than intrinsic, I like the job, I really want to do a good job. If the reward is extrinsic, there's a greater likelihood of exhaustion and burnout with those individuals. The other one is the motivation internal or external? If the motivation is internal, they like the work, it's interesting and engaging, then they're engaged by the work. They don't get burned out. What's the impact of workaholism beyond what we've just mentioned? One, it can contribute to marital conflict if the one individual is really over-investing in work and under-investing in the marital relationship or the partner relationship, whatever, then that can be problematical in those relationships. We also see a decrease in effective problem solving in the rest of their lives, right? They're just not invested in that. They can become overly controlling, which is not helpful in relationships. People don't like to be controlled. They try to control the situation and other individuals. And a serious one is a decrease in positive emotions, joy, happiness, calmness, contentment, and an increase in the negative emotions, the anxiety, anger, depression, guilt, all of those. The children of workaholics have been studied, and there has been found a higher incidence of anxiety among those children, a higher incidence of depression, and as they get older, they lack an internal locus of control and have more external locus of control, an extrinsic motivation than intrinsic motivation. And we notice, and remember, that if the extrinsic motivation is higher or the individual is afraid of punishment, that contributes to exhaustion. So having a workaholic parent can be a setup for later problems in the life of the child. If we look at the personality of the workaholic, excuse me, we see certain things, certain traits, and then also we know from the behaviorism model that we looked at and the motivational interviewing, and also for cognitive behavior, how one can go about treating these personality traits. These are treatable. They're not, a lot of people go, this is just the way I am. No, that is not the way we are. It is the way that we have practiced being into the world. But many people, by saying that that's just the way they are, won't take action to change some behaviors that may be helpful for them and increase their joy and happiness and decrease the negative emotions that they have, and also improve relationships. One is that the individual can have a high level of achievement, so they're achievement oriented. No problem with that if that is not overdone. Also, high anxiety, which of course we can treat. High levels of motivation, but sometimes that can be extrinsic motivation rather than intrinsic. High levels of impatience, which again is problematical in terms of getting the work done, and also in working with other individuals that can be problematical. And then also lower self-esteem. And what is low self-esteem? Low self-esteem is where we tend to rate ourselves low. And so individuals, sometimes the way they handle that is to try to do something so that they can rate themselves high. So if they rate themselves high based upon their work, that's problematical. A better treatment is not to rate yourself and then look at your performance within a role in terms of reaching the goal there. We talked about that when we were looking at cognitive behavioral therapies. So workaholism can be a way to overcome or compensate for self-esteem, but it is the wrong way to deal with self-esteem because they want to rate themselves higher than lower. The problem is rating yourself. So they're engaging in the rating game, which eventually causes problems. They also have higher levels of narcissism. Narcissism is not necessarily problematical, unless the individual is overly focused on the self and thinks that they are, much better than others and they're special beyond what other people are. That level of narcissism is not helpful. They will have lower negative affect. We've already seen that with depression, etc. Perfectionistic individuals, which means demanding about what they're doing, and then overly self-centered, which is a problem. Self-centeredness to the extreme is narcissism. So we want individuals not so just focused on the self, but of course focus on the self and enjoyment, but also focus on others and life and the world, etc., and have more balance in life rather than just focus on the self. A greater attachment to task orientation. So task orientation is helpful, but we need to know when to put the tasks down and move toward investment in interpersonal relationships and in hobbies and recreation and sports and all those other things. And then one is the typical type A personality. And a lot of people go, well, that's just the way I am. No, it's not just the way you are. It is the way that you have practiced into the world and actually have been inadvertently rewarded for that. And that can become so problematical that for some of these workaholics, they need to do something that I'm going to be talking about now, and that is additional treatments. The treatment for workaholics sometimes is to the point where they need to be go into inpatient. The problem with the inpatient is well, the good thing is it's taking them giving them a break from actually working, but it is very expensive and often insurance won't pay for it. So often that will be out of pocket when some individuals can't afford to do that. But there are outpatient treatments for that too. It's interesting. When we look at the treatment for workaholism, we can't it's not like substance use disorder where we would go, the goal is abstinence. Well, we don't. The goal can't be abstinence for work unless you're extremely wealthy, right? An individual needs to work to live and have the things that they want, etc., or to help others and themselves and the family. And so we can't have an abstinence model for workaholism. So we can't prescribe that. So what we are trying to prescribe then is to help them develop some social skills and life skills so they can live a more balanced life. There is a cognitive behavioral therapy specifically for workaholism. And one of the goals here is, remember, they tend to have really low self-esteem. Many of them, others just the opposite of that, narcissistic. Although an individual could be narcissistic and have low self-esteem at the same time. And so one of the things that we want to help those individuals with is have a healthy kind of unconditional self-acceptance, but also unconditional acceptance for other individuals too. Part of that cognitive behavioral treatment will to help them manage stress better, because remember, stress will activate the sympathetic nervous system, produce chemicals in the body like cortisol that are really not helpful to the body over a long period of time. Over the long haul, it depresses the immune system and can contribute to cardiac problems, etc. So stress management is going to be a tremendously important component of treating workaholism. Group therapy can be quite helpful. Family therapy, because sometimes we have to repair those relationships involved there. Two forms of therapy, in addition, that have really specifically looked at workaholism that have been shown to be really quite effective are Adlerian therapy. Sometimes it's not the easiest to find an Adlerian therapist, but if you can, that can be really quite helpful, especially if the individual, the therapist has had some experience with workaholism. And then rational emotive behavioral therapy, REBT, that was founded by Albert Ellis in the 1950s, can be a tremendous help. There's now a 12-step group called Workaholics Anonymous. Well, I thank you very much. We got through the lecture number 1 on the behavioral addictions. We have one more lecture number 2 on this topic, and then we will finish week 8. So thank you and have a great day.
The Masters of Arts in Addictions Counseling at Columbia International University prepares graduates to be successful in an occupation that is experiencing job growth at a tremendous rate. This program integrates faith with evidence-based knowledge and practice in diagnosing and treating addictive disorders from substance abuse to behavioral addictions. CIU's Master of Arts in Addictions Counseling is the only academic program within the U.S. to offer certificates in addictions counseling through the Albert Ellis Institute, an international mental health professional training institute. Enroll today at CIU.